Okay, today we'll be discussing bond and mismanagement, and in the course of this discourse, we will be following this outline. Bond is defined as coagulative necrosis of the skin and its underlying tissue. This definition of bond is considered as the most appropriate definition. And most bond is coagulative. However, some bond, particularly alkali bonds, they cause bond via liquefactive necrosis. So you may see in MCQ to ask you which of the following bond causes necrosis via liquefaction. Please, you can look for alkali bonds. Now, how do you classify bond? The particular type of classification you know about is what they classify based on degree: first degree, second degree, third degree, and fourth degree bonds. So that first degree, second degree, third or fourth degree bonds, they basically also represent a type of classification where this bond is classified into three major groups: superficial bonds, partial thickness bond, and full thickness bond. Now, for superficial bond, what I say, this simply means bond that involves the epidermis. For partial thickness bond, it's bond involving the epidermis and the upper layer of the dermis called the papillary dermis. In deep partial thickness bond involves the epidermis up to the reticular dermis, and the full thickness bond involves deeper tissue such as fat, muscle, bones, etc. Now again, one can basically classify into superficial bonds, partial bond, and full thickness bond. Partial thickness bond can be further subdivided into superficial partial thickness and deep partial thickness bond. Are we communicating? If you have questions, please you could ask, and I will be there to guide you. Now, for the superficial bond, we say it can be called first degree bond. The partial thickness bond, which is further divided into superficial partial thickness, is called second degree bond, and the deep partial thickness is called third degree bond. Having said this, now how do all these bonds, how do they present? Before we go to their presentation, there's also another form of classification which is based on how it occurs, the etiology. And in this type of bond can be, when bond is caused by a fluid, it's called scald bond, particularly when it's caused, and in our environment, the common cause of scald bond is hot water bond. When it's caused by fire, it's called a flame bond. When it's caused by a chemical agent, it's called a chemical bond. When it's caused by electricity, it's called electrical bond. When it's caused by contact with hot surface, it's called contact bond, such as bonnet in exhaust pipe in an Okada. When it's caused by rubbing of the skin surfaces in another surface, such as the coal tar during an accident, is called frictional bond. Now, how do bond occur? For bond to occur, there have to be an exchange of energy between the causative agent and the skin, in which the resistance of the skin is breached. What this simply means is that whatever is the causative agent, either be it flame, be it hot water, be it electricity, be it chemical agents such as acid and alkali, there's an exchange. This chemical agent gives an energy which can be in form of heat, which can be in form of chemical reaction. And this energy overwhelms the capacity of the skin to resist it. As such, what that means that the heat itself that comes into the tissue denatures the protein cell membrane. And once it denatures it, what then happens eventually is that these cells start dying. And when they start dying, they start releasing inflammatory mediators. These inflammatory mediators helps them to now cause the cascade of events that occur during burn. Now, once the membrane layer is burned, fluid is able to penetrate from the intravascular component to the extravascular component. Particularly of interest is on the outside of the cell membrane is a layer called the glycocalyx layer. In bone, that glycocalyx layer is damaged. And what that glycocalyx layer does in the physiologic state is that it helps to prevent or reduces the flow of fluid, particularly plasma proteins, from the intravascular space to the extravascular space. But once this glycocalyx layer is damaged, there's free exudation of fluid from the intravascular place to the extravascular space, and that is one of the reasons why we have bone wound edema. Also, to this inflammatory mediators such as histamine, serotonin, bradykinin, they cause vasodilatation. And when there's vasodilatation, fluid pulls into the extravascular space also too. And then once this process is not arrested via intervention, there's intravascular contraction. That means the amount of fluid necessary necessary to maintain circulation in the intravascular space is further reduced. There's hyperviscosity, and then the cascade continues. Bone shock occurs, and then the patient further deteriorates and succumb to the bone injury. Having said that, now let's look at how this bone present. Again, we said bone can be either superficial, it can be partial, it could be full thickness. Superficial bones are usually the bones that involve the epidermis. And commonly, bone you see in sunburn is the common example is sunburn wound. Someone working there, just someone leaving his house and then entering into the hot sun, suddenly start feeling pain in the skin. Now, and then if it is light skinned patient individual, person will start noticing that part where he's feeling pain is reddish. However, if it's dark skinned individual, he may not see that reddish discoloration, what's called erythema. What you may see will be darkish coloration of the skin, and the pain is severe. So once someone having presented to you that he will walk into the sun and suddenly start having pain around the area of his skin, and it is reddish or his darkish in coloration is painful, then thinking that is sunburn. Usually sunburn heals within 24 to 72 hours. We don't, as surgeons, treat superficial burn. And I'll also give you an information to very important in your examination, in case I forget. Now, for plastic surgeons, or for surgeons particularly, our treatment commences from partial thickness bone to full thickness bone. For superficial bone, we don't treat such. Hence, in your exam, a question may present like this: that the patient was involved in a bone, had a fire incident and sustained burn to the entire upper limb, entire lower limb. So sustained burn to the right upper limb and to the left lower limb. And then they will not tell you that the bone in the left lower limb is superficial bone. The bone to the right upper limb is partial thickness bond, what is the percentage bond for this individual? So please keep thinking about that. When I finish, you'll give me the answer. Are we together? Are we together?
Yes.
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 Now, again, like I told you, in superficial bond, we don't calculate superficial bond. So our calculation starts from partial thickness bond.
Okay.
So to help you with the answer is this. Now they tell you that the bond in the upper limb is superficial bond, the bond in the upper limb. So they say the bond in the lower limb is superficial bond, the bond in the upper limb is superficial partial thickness bond. You don't calculate the part that involves the lower limb. You only calculate the part that involves the upper limb. And based on the calculation, which you will get to know later, there's the rule of 9 called the Wallace's rule of 9. So that is what is used to calculate it. And if you say the entire upper limb, the entire right upper limb is 9%, so that patient has 9% bond. And what you will see in your option will be the entire lower limb is 18%, left lower limb is 18%. 18 plus 9 is how many? It's 27, I mean. So you see 27% in your option, you see 18% in your option, you see 9% in your option. The answer will be 9%. Are we communicating?
Yes.
Okay. So now, again, the question will not just come and tell you that this is superficial bond, this is partial thickness bond. The question may come up in another form, whereby you just give you the symptoms, what's found in the lower limb. We may just tell you that what is found in the lower limb was erythema in the entire lower limb, erythema, and very tender. That is that superficial bond. While in the other upper limb, they will give you the features of the other part, which I want to give you now. Now, for superficial partial thickness bond, now the thickness, the different classification of bond is a clinical diagnosis. It's not a laboratory diagnosis. It's what you observe that you make that you can use to classify the bond. So for superficial partial thickness bond, what you see multiple small blisters. If it did occur to me that I've actually kept some pictures so that although I wouldn't have been able to put the pictures because permission was not taken from the owners, from those patients, and then this thing may go on YouTube. So the patient sees such videos, it may breach privacy. So of course, maybe that was what I was thinking why I did not put those pictures. Yes, if it was just maybe lecture that I may not place on social media, I may have just kept the picture. So by the time I'm talking, you could see, and then it makes sense to you. However, for the purpose of the exam, now superficial partial thickness, but how will you differentiate that? The blisters are multiple and they are small. When you see small multiple blisters, it's classical for superficial partial thickness bone. Then the skin, again, when you look at it, you see that the hair pores are standing, they're erect. Then once you rupture those blisters and then you look at the skin, you apply pressure on it, it blanches. What it means that it blanches that as soon as you apply pressure, it becomes pinkish. So it becomes pale. As soon as you remove your hand, it becomes reddish, or it returns to its original color. So again, classical of superficial partial thickness bone is there's multiple small blisters, very classical of it. The skin blanches, the hair pores are erect, and there is pain. However, the pain is not as severe as superficial bones. For deep partial thickness bone, the bone blisters are larger. We see large blisters, sometimes up to 5 cm, sometimes up to 3 cm blisters. The skin is non-blanching. I'm sure you apply pressure. The skin is once you open the blister, the skin is reddish, erythematous. And once you apply pressure, it does not blanch. There is pain, but the pain is on deep palpation. Are we communicating? Am I communicating?
Yes, sir. We are together.
Okay. So for full thickness bone, the skin is leathery. If you have seen exactly the classical way I would describe it, it's like pomo. You know pomo, Navi? You know, pomo, meat.
Common. Oh, yeah. Common
Yeah.
meat. Yeah.
That's how the skin is. It's leathery like pomo.
Okay.
Sometimes it can be darkish. Sometimes, especially when you involve the digits. Then there's no pain. If you like, use a blade to cut the patient's skin, you won't feel pain. So that's classical of the various degrees of burn. That's for the classification of burn. Having talked about that, what is the principle of management of burn? The principles of management are hereby highlighted. The first is fluid administration, pain control, tetanus prophylaxis, wound care, antibiotics, supportive care, such as ulcer prophylaxis, Dvt Prophylaxis, nutritional physiotherapy, rehabilitation. So we're not talking about the various subheadings or the principles. In the fluid administration, once you see a burn patient, the first thing you want to do is, first of all, know the total burn surface area, right? So once the total burn surface area is more than 20%, you must set line. Again, before then, burns can be classified as major burn or minor burn. A major burn is burn in which the percentage burn area is more than 15% for partial thickness burn, or more than or equal to 10% for full thickness burn. This is for adult figure.
Sorry,
For
I don't understand.
pediatrics, sorry?
I don't understand. Because, like,
I
can you
said burn again, burn generally can be classified into two major burn and minor burn. I gave you two classifications earlier on. I gave you based on thickness into first degree, second degree, third degree, fourth degree. We can also be superficial partial thickness, superficial bone, superficial partial thickness, deep partial thickness, and full thickness bone. I also say bone can also be classified based on etiology into flame bone, chemical bone, electrical bone, contact bone, frictional bone, among others. I'm not saying that it's still another classification of bone again, where you can classify bone into major bone and minor bone. Are we communicating? Are we communicating?
Yes.
Okay. So for major bone, it is bone in which the total bone surface area is more than 15%. That means the part of the body that is bone is more than 15%. When it is partial thickness bone for adults, right? So if the bone is full thickness bone upon your assessment and it's more than 10% for adults, it is a major bone. If the bone is more than 7.5% bone surface area and it's pediatric patient, it's a major bone and it's a partial thickness bone. Again, if it's a partial thickness bone and the total bone surface area is more than 7.5% of the entire patient body and it's a pediatric patient and it's partial thickness bone, it's a major bone. If it is full thickness bone and the patient is a pediatric patient and the total bone surface area in relation to the entire patient body surface area is up to 5% or more, so for full thickness bone is called a major bone. Are we communicating? Are we communicating?
Yes, sir. We are with you, man.
Okay, because this is very important in the management.
Okay.
Questions can come out like this. Okay. Having said this, we now continue our management. Now, once you assess a patient and then you make your diagnosis that this patient is a major bone, it's major bone, you set IV access. You pass urethral catheter. Then once, again, the preferred fluid for resuscitation is Ringer's lactate. You can start in your exam. They will give you a question that the patient had bone and needed fluid for administration. The question can come out like that, and they will ask you what is the preferred fluid. You will see normal saline, then you see Ringer's lactate, then you see dextrose saline, then you see dextrose water there. The answer is Ringer's lactate.
Okay, sir.
Are we communicating? Are we communicating?
Yes, sir.
Okay. Now, how do you calculate the total bond surface area? If there's a patient bonds itself, and then you need to for you to calculate the fluid the patient needs, you need to know the total bond surface area. I mean, the part of the patient body that is bonds in relation to the entire patient body. There are certain formulas we use. Is what we call the Wallace's rule of 9. WALLACE'. Wallace's rule of 9. This Wallace's, what he does is that what he did was that he ascribed various parts of the body, giving them a figure. He said the entire head and neck region is 9%. The entire upper limb of one part of the body is 9%, of the right is 9%. The entire upper limb of the left is 9%. He then said the anterior chest is 9%. The posterior chest region, the entire posterior chest region is 9%. The abdomen, he said, is 9%. The back is 9%. That means below the chest region, back below the chest region is 9%. He said the entire lower limb, right, is 9%. The entire, so it's 18%, sorry. The entire left lower limb is 18%. Again, I come again. He said the entire left lower limb is 18%. The entire right lower limb is 18%. The entire right upper limb is 9%. The entire left upper limb is 9%. The head and neck region is 9%. The upper chest, so the chest, anterior chest is 9%. The posterior chest is 9%. The anterior abdomen is 9%. And the back below the chest is 9%. If you do all this sum, you have 99%. He then says if the bone involve the perineum, you make it 1%. So if you do this calculation, this will give you 100%. So here comes your question. Now, if you see a bone wound, you see the bone involve arm, right?
Yes.
If you involve the arm is 4.5%. You know, if the entire upper limb is 9%, then arm will be about 4.5%.
Mm.
Am I communicating?
Yes, sir.
Okay, fine. If you have any question, please feel free to ask, please.
Okay, sir.
Okay. Feel free to ask if you have any question.
Okay.
Okay, so the entire part of the body has been mapped into 99%. So one way of calculating the total bond surface area. Another means of calculating the total bond surface area is what we call the rule of palm. The palm, again, let me describe what the palm is. So you can see my arm. The palm is from this web space up to the distal limit of the flexor retinaculum. This region here is the palm.
Okay.
So in the rule of palm, you take the patient's palm, which is from here, right, to this point.
Yes.
You ascribe this, it's the patient's palm, it's not your palm, the patient's palm. You ascribe this total palm as 1%. So you can then take a sheet of paper or a clean material, trace the patient's palm on it, right? Start using to map the part of the body that is involved. So if you're able to map 5, that is 5%. If you're able to map 10, that's 10%. If you're able to map 30, that's 30%. Again,
Okay.
if you can use the patient palm directly, better. But sometimes some part of the body, patient palm cannot get there. So you have to use something to map the patient palm and then use that map we use, and then start placing on the bond area to calculate the total bond surface area. Are we communicating?
Yes, sir.
Okay, that's the rule of PAM. Another way of assessing the percentage bond area is the long and broader chart. That chart is commonly used as an inpatient basis. It's more accurate, however, but it's very cumbersome. So what you may see in your exam is which are the if long and broader comes out on your exam, they only come out like which of the following can be to access total bond surface area. You may see it as one of the options: long and broader chart, rule of PAM, Wallace's rule of 9, all of the above, none of the above. In that instances, all of the above is the answer. Are we communicating?
Yes, sir. Yes, sir.
Okay, so having known the total surface bond area with this formula, so again, if they tell you that patients of sustained bond to the right upper limb, right, and then now tell you that the bond in the right upper limb has blisters, the blisters has blisters and is tender. However, it also sustained bond to, let's say, the thigh of the lower limb, of the right lower limb. There was no blister and it was painful. And it was very painful. They will tell that the pain in the upper limb is painful. The pain in the lower limb is very painful. But the pain, that in the upper limb has blister, that in the lower limb doesn't have blister. We now ask you what is the percentage bond area? So in that instance, if they see the entire upper limb and the thigh, you know, the entire upper limb is 9%, the thigh, you won't add the joint as your bond surface area. Are we communicating?
Yes, sir.
Okay. This is very important in your fluid and administration also too. So to know the amount of fluid you will need to give to this patient, there's what we call the Pac Plan Formula. There are various formulas, but I will not bore you with those ones because those ones may likely not come out in your exam. It's the Pac Plan Formula that may likely come out in your exam. And for the Pac Plan Formula, what it simply means is, I'm coming. Okay, for the Pac Plan Formula, what it simply means is that it helps you calculate the amount of fluid that the patient may likely require. So the formula is use 4 mils times that total bond surface area you calculated, either by the use of Wallace's rule of 9, the rule of PAM, or the long and broader chart. That total bond surface area you calculated, you will times it by 4 and times it by the patient weight. So this question can come out like this. So say, okay, this patient had, they may actually help you and say patient had 34% bond surface area. Patient weight is, let's say, 70 kg. What amount of fluid the patient require for resuscitation in the first 24 hours? In that instance, you just times 4 times that total bond surface area that they gave you and times the weight. That will give you the amount of fluid required. Sometimes this will may become very trickish. They will not give you the total bond surface area. They will help you, will allow you to calculate it. They will tell you that the patient sustained bond to half or to, let's say, to the arm. No, they will tell the patient to sustain bond to the entire upper limb, so entire lower limb, the abdomen. And then after the patient weight is 70 kg. What amount of fluid the patient require? In that instance, you will now need to say, okay, if the entire upper limb is 18% and the abdomen, anterior abdomen is 9%, 18 plus 9 is 27. All right, yeah. So 27 times 70 times 4 will be the amount of fluid the patient will require for fluid resuscitation. Are we communicating? Are we communicating?
Yes, sir.
Okay. So the next thing they will not ask you will be, okay, how will you administer the fluid? Now, that fluid you calculate, half of that fluid will have to be given over 8 hours. The remaining half you give it over 16 hours. Are we communicating? So if, let's say, after calculating that stuff, with that formula, you got like, let's say 6 liters, you have to give 3 liters over 8 hours, and then the remaining 3 liters over 16 hours. I guess we are communicating, right?
Yes, sir.
Okay. Having said that, there can also be another catch again. The examiner may say, okay, patient presented to you 4 hours after born. What is the amount of fluid to be given? Right? We'll now say, okay, after calculating your fluid, right? With that formula of 4 times total bond surface area times weight. That's okay. The first, and the options will be like this in the option. What you see is that give, let's say you calculate 6 liters now. One option will be give 3 liters in the, and I told you the patient came 4 hours after born, and the fluid after calculation was 6 liters. How will it administer the fluid? That's how the question will come out. First option you may see is give 3 liters over 8 hours. Second option, give 3 liters over 4 hours. Third option will be give 6 liters over 24 hours. Fourth option will be give 6 liters over 16 hours. Now, if the patient comes 4 hours after born, it simply means that that amount of fluid they are supposed to give over 8 hours, you will have to give it over 4 hours. So the answer will now be 3 liters over 4 hours.
4 hours. Okay.
Yes. Are we communicating?
I understand.
Okay, fine. So these are some of the tricks that they may use in your exam to want to bulldozer you. When you are giving your fluid, you must monitor your urine output, and you want to aim at 0.5 to 1 ml per kg per hour for adult and 1 to 2 ml per kg per hour for children. Once you are giving your fluid, again, for superficial burn and partial burn, they are usually painful, so you want to give the patient analgesia. Pain medication.
Sorry, can I ask a question?
I'm with you.
Yes. On this last point here, you mentioned that we should
Sorry, could you speak louder a little bit?
Okay. The last point, it said that we should monitor the fluid therapy at 0.5 up to 1 ml per kg. Like, what does that mean?
Okay, what that means is that now the amount of urine the patient makes an hour usually will be maybe 30 mils, 40 mils, right? So every hour that urine must be emptied from the urine bag and measured. How you measure it, you may get like maybe 40 mils, sometimes 200 mils, right? Are you listening? Are you understanding me?
Yes, sir.
Then that amount of fluid you get, that amount of urine you get, you not divide it by the patient's weight for that hour. So if you get, let's say you get 35 mils and the patient weight is 70 kg, so that will be 35 over 70, and that will give you 0.5 mils.
0.5 mils per kg per hour. Okay.
Yes, so that will be 0.5
Understand.
mils per kg per hour. That means the patient is making adequate urine. Or the patient makes 70 mils, you now divide 70 by the patient weight, and you get 1 mils. That will be 1 mils per kg per hour. Are we communicating?
Yes, sir. Yes, sir.
Okay, so that's how you calculate for the fluid to be administered. Now for tetanus prophylaxis, I will just leave this slide. You will read it. If you have questions later, you can put it in the YouTube channel. I can give explanation to it. Or you could read this once you get the video, you could pause it and look at it properly. Maybe if you don't understand, maybe in subsequent lecture, I can give it to you. I can explain to you rather. But this is how you give tetanus prophylaxis for these patients. So for wound care, what you do is that you do serial dressing of the wound for these patients. Then again, the question will come up. The question will come up like this. Having dressed the patient wound, what are those signs that you see that will tell you, that will make you want to change your dressing? If you are seeing that dressing is stained, you have to change your dressing. That's a classical sign that tell you that you need to change your dressing. Then the next thing you want to give is antibiotics. Now, antibiotics commonly is for bone wound. Bone wound is considered a sterile wound, except there is contamination. Now, if patient sustained bone wound, and then from the bone from the bone event itself, patient was aseptically moved from the bone event center to the bone unit of the hospital. Such a patient wound is considered sterile. But in our environment where we find ourselves in Africa, before the patient would have come to see you as a doctor, you must have applied one herbal concoction or the other. They may have applied egg, may have applied honey, even the water that they want to even use to help the patient to cool off, maybe dirty water. The means of moving the patient down to the hospital, maybe from motorcycle, dust everywhere. What patient gets to you, that one is already contaminated. So most wounds in Africa, particularly in Nigeria, are contaminated wounds. So in that instance, you have to give antibiotics. Now, for the antibiotics, commonly the group of organisms that the patient may have in the first week of presentation will be likely gram-positive. And then with your dressings alone, that most times can suffice for that, because one of the dressing agents you use will contain antibiotics. So commonly, usually by the second week where there will be gram-negative colonization, that's when antibiotics may be very useful. Now, these patients, bone patients, especially for the major bone, they may have some stress. Bone is a stressful process for the body, of course, and then they are prone to what we call stress ulcers. And that ulcer you will see in your exam is Collins ulcer, C-U-L-L-E-N-S, Collins ulcer. Now, there are two types of ulcers that you may meet in your exam. There's what we call Cushing's ulcer. There's what we call Collins ulcer. And the Collins ulcer is usually how the question may present with a patient had bone wound and they develop pain in the abdomen. Question may be what's your diagnosis, Collins ulcer. Sometimes they may jump diagnosis and tell you what will be your management. You may be thinking they will put things like diclofenac and analgesic, may put things like paracetamol. The answer to that stuff is anti-ulcer medication. So in that option, you will now begin to look for things like any anti-ulcer medication, such as cimetidine, omeprazole, Gestid, Gascol, and Gaviscon, and co. Am I communicating? Am I communicating?
Yes, yes, you are.
So again, for the Cushing ulcer, the material that patient had road traffic accident and was unconscious for some time, and then subsequently started having epigastric pain. What's your diagnosis? In that instance, the answer is Cushing's ulcer. The same management you give the patient, you give ulcer prophylaxis for this patient. Now, Dvt prophylaxis commonly for major bone is useful, especially if the patient is at risk for Dvt. For instance, for major bone, these patients are usually confined to the bed in the early days of their presentation. So, and that's a risk factor for Dvt. The patient is also fat in addition, it's also a risk factor for Dvt. Patients having bone itself is also a risk factor for Dvt. So once you have major bone, patients confined to the bed, you want to give Dvt prophylaxis for this patient. Again, you want to recommend the patient on high protein, high calorie, high protein diet to help the patient. For burn is a catabolic process. You want to help bring good nutrients that will help to promote the anabolic process of wound healing. Early physiotherapy is very key for this patient to ensure that they regain their range of motion. Having said this, some of the complications of burn wound could include dehydration, electrolyte imbalance, shock, pain. Other complications that we may get later may be contraction, hyperpigmentation. Patient may have psychological pressure, psychological symptoms such as depression, psychosis in some instances. So these are patients that you want to also give supportive care to while the treatment is being carried out. So thank you very much for listening. If you have any question you want to ask me, queries?
Sorry.
Sorry?
I would need can you send this into our group chat, please, if you don't
Sorry,
mind?
I'm not hearing.
Can you send this presentation into our group chat?
That's the point. The point is that I will not labor this hard to come to this presentation. Nobody is even in the forum.
Okay.
Okay,
Okay,
so
understand.
it doesn't. The point is that